Thank you so much again for having me here today. So today I will talk to you about sex differences and the endocannabinoid system in pain. So before we go and talk about pain, I wanted to make sure that you all know that, and you see that slide, which part of a review that I did when I just started my postdoc in Georgia, and we were asked to do a general review on pain for undergrads in a psychology book, basically the handbook of psychology, so and of the neuroscience. And I wanted to emphasize that pain evolved greatly throughout the years. So from the ancient Greeks to Descartes to Max von Frey here, that you could see, we as of today use this filament, which I will show you now. We have digital electro von Frey, which are from Max von Frey in 1894, 1895. So, and then the pioneer of the gate control theory, which Mezak and Wall, that are from Medial group, that have really revolutionized the field of pain. And pain 70 years ago, if you didn't have any injuries, was perceived as a psychological or psychiatric illness and was treated differently, right? So maybe it looks far away 70 years ago, right? But we really need to emphasize that pain medicine, management of pain, have truly evolved during the last couple of years, and even since I started my PhD in 2002. So with further ado, I will let you talk about the IASP, for International Association for the Study of Pain. So basically international organization, for those of you who don't know, and really relevant for med school students, because they have like meetings and they have clinical research and basic science research. So I'm throwing it out there for med school students, but it's really important groups that shows try to bridge clinical and basic science. So basically pain as of today, the definition has evolved as the evolution and perception of pain and its treatment. So pain is, as of today, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, which means that you can still experience pain, although you don't have any, the injury is gone. It's, let's say, not shown on the MRI, and you broke your knee, for example, and you still perceive pain, but the injury is not there anymore. So it's still possible. And some people are born with congenital analgesia and basically don't feel pain. So this slide, I wanted to emphasize that we define pain, but as you can see here, I have a pain in the middle, but there's 3 dimensions of pain. So cognitive, affective, and sensory part of pain. But pain, for most of the time at the clinic, we address the sensory part of it. Emergency situation, you broke your knee or you're really in pain, abdominal pain, different things like that. It's really the sensory aspect. But chronic pain and persistent pain can lead to affective component, which will lead depression and anxiety, and also cognitive aspect of it. So it's important to keep in mind that these 3 dimensions of pain are all merged together to make you experience pain. And it's not just due to the sensory aspect of it. And there's different factors, obviously, as you see here in this slide, that will affect pain. On the other slide, I wanted to show that pain will be perceived at different sites, intensity, duration, and quality. And that's what physicians in the clinic have to deal with when they receive patient. And that's always worrisome if you have experienced chronic pain. So this is basically the slide about nociception and the sensory transduction of information. So basically, if you injure yourself, as you can see here in the cartoon, what you can experience, you will see here that you feel pain, it will go all the way to your brain, and then you will have descending modulation of pain that you will see in the next slide. I don't know why I can change my slide now. Okay, yes, sorry about that. It was a lag, technological lag. So basically here, as you can see, pain is transmitted. You have pain all the way to all different brain regions, and you have also descending modulation of pain to kind of alleviate pain temporarily. So, and also a long term. This is to show you how we basically can evaluate pain in the clinic. And there's different scale or depending on the patient, right? If you have little infant, you will have to look with the crying and the like the face, like the expression of the face. But for little kids, you can, when they're able to recognize faces and things like that, you can look at the smiley face, you can use a verbal rating scale, the visual scale, and also the Medial pain questionnaire, which actually look at the 3 categories of pain. So it is important that the 3 categories of pain that I mentioned, the Medial pain questionnaire really address the sensory, affective, and cognitive part of pain. And it's basically described by different words, but this questionnaire takes a little longer to take, and sometimes we're not using it like repetitively in the clinic if it's kind of in the context of a time, we are limited on time. But it's really important, and it's really been used and really translated in different languages. So it's really an important questionnaire. So NIH decided in 2016 to basically kind of emphasize the importance of sex differences, right? So they said that we need now in the studies to consider basically the design, in order to design sex differences. We also need to collect studies about sex differences. We need to characterize and basically try to publish as much as possible and to report sex differences to advance the field. So sex differences, Jeff Mogil, which has been known in the pain field, and it's interesting that I know him from when he started as a young research assistant professor back in the old days when I was a PhD student. So it's really interesting to see all of these famous people in the pain field that have evolved greatly in their career. But that's what I wanted to show here, is that this is the studies basically, right? Mostly preclinical studies. When I refer to preclinical, I mean basically animal-based studies, right? Versus clinical studies are linked to clinic patients, right? So sex differences are increasingly being studied, but we still need way more studies to better understand the field. And basically, whoops, sorry. It seems, I don't know if, okay, yes. So basically you can see here that there are more bias, more likely to see effect in male versus female. There's a bias there, and also females bias towards pain sensitivity versus the male bias towards the analgesic effects. So it's kind of complicated, but basically what it means is there's big bias. There's a bias for even experimenters that are doing studies in the lab. Dr. Mogul did a nice paper about that, if it's a female testing animal versus a male. And there's also a bias for the animals. If we do animal studies, I'll come to that later, and also in the clinic as well when we treat patients sometimes. So this is to show you sex differences in pain that has been published by Sorge and Torch in 2017, and it's basically sex difference in human. So basically greater prevalence of pain in women, mostly musculoskeletal, abdominal, and migraine. And women have a lower tolerance in experimental studies. So if you do experimental studies to try to understand pain in women, they have lower tolerance. So that's kind of complicated, right? The findings, or make it not as clear. Differences in evaluation and modulation of pain. Also we have difference in the representation in brain areas, and we're just starting to discover the differences. We've seen it in fMRI for men and women, but we just are starting to try to understand sex differences. So now I will go into the cannabinoid field. So most of you have heard about different words used for cannabis sativa, so marijuana, pot. You can go on a big list, and it's been really popular, and it's been the subject of the Times recently with CBD here. So I wanted to show you guys that. So there's a lot going on in the field. So back in 2002, we were just starting to evaluate cannabinoid. I was in Montreal, and they were trying to set up clinical studies, and the field has evolved really greatly and amazingly. So what I wanted to emphasize is that, as you can see here, cannabis sativa is the European plant, and that's the one we most found here. But there's also cannabis indica, which is the Indian plant, and cannabis ruderalis, which is part of Asia and Siberia. But the plant itself, it's important to know that there's 460 known chemical constituents. So there's more than that. There's 66 that have cannabinoids-like structure, and the delta-9 THC that was discovered by Gownie and Mechulam, and Mechulam actually is still alive. He is active in research, and he's really amazing man, still doing cannabinoid research and really interested, and was the one that really in Jerusalem started the studies with CBD and epileptic children. So that he was the one that started that like years ago, and look into that. So basically, this is just to give you an overview for those of you who are not in the cannabinoid field, but basically cannabinoid has been used for a long, long time, from in the China pharmacopoeia to Osanese prescribing it to his patient, which was a physician, to all the way to 1964, important date because Gownie and Mechulam discovered the structure active component of THC. And then the discovery of the CB1 and the CB2 receptor, Matsuda and Monroe, and the endocannabinoids, and all of the clinical trials and the basic science preclinical studies that have been followed. So as you can see here, cannabinoid receptors, CB1, CB2, will emphasize on these. There's new receptors that are cannabinoid-like receptors. There's a big debate in the field if they're part or not, the GPR. So we're not going into that today because it's still a debate. But the one that are part of the cannabinoid field are CB1 and CB2. So CB1 is responsible for the central effect if you take a THC versus, and are found in from the periphery to the central and spinal brain region. And then CB2 are mostly immune function expressed in the periphery, can be activated if there's injury, central nervous injuries. So basically, this is just to show you the CB1 receptor or GI coupled GPCR found throughout the CNS and the peripheral nervous system. Importantly, that's what I was just saying. Activation of CB1, basically responsible for the psychotropic effect, and basically produce analgesia, hypothermia, decrease in motor activity and coordination. And there's some more details about the specific molecular mechanism of action if you're interested. So basically, CB2 found in peripheral tissue and immune cells, as I said, can be induced in the CNS injury and in inflammation and neurodegenerative disease. But this is really a new field, and some people are still debating. So basically, this is new. We thought that they were not found in the brain, and this is a new field of studies, basically. And also have an analgesic effect. And the CB2, what they're really mostly famous for is that they produce analgesia without developing tolerance. And there's been we've been trying to use basically CB2 for different clinical trials. So cannabinoid receptors, there's CB1, as I told you, and CB2. It will sound like I repeat, but when I show you my study, it will be really, really clear for you that I'm talking about a CB1 or a CB2 or a mixed agonist, so you can follow what I'm presenting here. So CB1 and CB2, this is an overlap of the two receptor. In blue is the CB1, in green is the CB2. Endocannabinoids mean you produce endocannabinoids in your own body. So if you hurt yourself, if you're running, then you will produce endogenous cannabinoids. So everybody produce endogenous cannabinoid, like we produce endogenous opioids in our body. We also produce endogenous cannabinoids, and there's some overlap with the opioid and the cannabinoid system. I will not talk to you about that today, but if some of you are interested, you can email me, and there's really interesting study out there. So, and there's a synthesis and degradation also of the endocannabinoids, and then you can play around with these enzymes. So we developed a FA-MGL and DGL inhibitor to play around with the endocannabinoids, basically to increase their level. So in this slide, I wanted just to show you that I talked to you about the plant marijuana, and I talked to you about delta-9 THC, but we developed and we created synthetic cannabinoid. Those CP55940 is a mixed CB1, CB2, like delta-9 THC, that is a synthetic cannabinoid. We have also WIN, which is a CB1, CB2 agonist, and also HU210. There's also endogenous agonist, anandamide, and 2-AJ. that are produced in your body and also were synthesized for us to be able to do animal studies. And we have antagonists, SR1, SR2, mostly known, and we have other antagonists as well, as you will see in the next slide. So this is the next slide to show you the importance of the different cannabinoids. Like I explained to you, the plant itself, marijuana, has a lot of components, right? Over 66 active components. So from these components, there's alpha-9 THC, and there's CBD, and there's CBS, cannabinoid. But what I'm going to talk to you today about is I'll show you studies about the natural agonist and the synthetic agonist. So, and I'm not going to go ahead with the antagonist because I will need like a 2-hour talk to talk to you about all of the detail of the cannabinoid field. As you can see, it's my passion. But I will talk to you about cannabidiol or CBD. Important to know, it doesn't bind to CB1 or CB2, and it's not psychoactive properties. And so it's different than THC, right? I'll talk to you about THC. I'll also talk to you about ACA, which is a CB1 specific agonist, as you can see here in the chart. And I'll talk to you about AM1241 and GWH as well, that are CB2 agonists here in the chart. And CP, which is a mixed agonist. So now I'm going to go with CBD. CBD, I could go on for a long time about CBD because that's the subject of the news and there's a lot out there, okay? CBD is part of the plant. And it is non-psychoactive. So if you guys can remember, if it's a take-home message, it's non-psychoactive, doesn't bind to CB1, CB2, it's bind to GPR and other receptors. It's still mechanism of action is still being investigated in preclinical studies. And we call it cannabidiol or CBD. And then there's a lot of things out there. There's cannabinoid, CBD oil. There's things for pets as well. It can be used for pets for pain. So it decreased seizure, and the origin of that was Dr. Gauni Mechlam that discovered alpha-9 THC, basically did investigate the effect for children that had a lot of seizure, and they tried that in Jerusalem in clinical trial like a few years back, and they pursued that, and he pursued that, and then now that's where we are. A lot of we're having CBD, right? So decreased seizure, pain relief for different pain conditions. It can become arthritis, low back pain, injury from your knee if you broke your knee and things like that. Reduce inflammation, antidepressant, can improve headache, migraine, and sleep, and reduce stress, okay? So there's a lot of things. There's creams, there are beauty products, CBD, there's gummy bears, there's different things, okay, out there. So what is important is that, as I mentioned to you, this is the effects of cannabinoid on different physiological system, right? So they're used for reducing glaucoma and different things like that. Today, I'm going to focus on analgesia, the effect of cannabinoids on analgesia and the development of tolerance. But there's other properties that they are used for. They are used in cancer a lot for their antiemetic properties and stimulant of appetite, and also decrease nausea and things like that to basically have cancer patient gain weight, right? So they're used a lot. So this is the map, okay, the US, the states with legalized marijuana. So there's a little chart right here, as you can see. So recreational and medical marijuana use is basically the darker green color. Then the marijuana use is not legal, is on these white spots, all of these white states, right? But then there's medical marijuana that is lighter green, right? But that was basically 37 states. But I'm going to show you a new map. This is the latest new maps. So that's a little bit better. It discriminates better the states that have CBD. So it's similar, but as you can see in gray, CBD use only permitted. So some states allow CBD use. As you can see, Wyoming, Kansas, Texas, and so basically you can go Kentucky. So you can go you can see all the gray spot. The green, dark green means medical and recreational cannabis. And the lighter green is basically medical use only, and some are just CBD. And to be noted, some states are basically red, meaning there's nothing that they don't allow basically Idaho and this over there, they don't they don't allow cannabis at all. So this is the latest ones. Okay, so that's the latest one. It's maybe changed in the next couple of years, right? And there's new advocates, a lot public people and personalities and celebrities now are talking about CBD. So CBD has a big momentum right now in the cannabinoid field, basically. So again, I put again CBD, same structure, but then I'm going to go on for my clinical studies. But this is basically the main effect of CBD. It's been used and kind of popularized by some celebrities and people that kind of talk about it and things like that. So cannabis and pain. So this is really important picture here and slide, because it really shows that medicalized states here versus the non-medicalized states. And that's back from 2019. But as you can see here, chronic pain, as lower chronic pain in states, the percentage of chronic pain is lower in states that have medicalized cannabis versus the non-medicalized states. So it's really interesting, 33 versus 68. So it's really important, right? So that's really, there's other condition that you can go look on. Like I told you, glaucoma, multiple sclerosis is a big component, also 27 to 14. There's also chemotherapy-induced nausea and vomiting. This is a big percentage here, right? So there's different condition, basically medical condition, but it's really striking the impact basically on this slide. So here, this is a review that I did with Henry Blanton, my first PhD student, which was highly productive and just graduated. So I want to congratulate him from graduating his PhD. So basically, we did a review back in 2019, and we wanted to look at the cannabinoid, the current and future option to treat chronic and chemotherapy-induced pain. And what I want to emphasize is, you guys can look it up. Drugs is a journal actually that is also read a lot by physicians, and we wanted to kind of address the treatment for chemotherapy-induced pain, so the three chemotherapeutic class, but we also look at clinical studies and preclinical studies. We look at both for cannabinoids. So what I wanted to show you, this is a big table. You could just go look at the manuscript. What I want to emphasize here is we looked at chronic pain, and as you can look here, this is basically chronic pain. You have HIV, you have neuropathic pain due to different things. It could be etiology, it could be surgery, different things like that. And then this is the gender. So this is the studies. And when we did the table, we look at male versus female, and so 2018 will be 20 male, 18 female. So that goes on and so forth. But basically, most of the studies are really, really small studies, right? So this study was the 96 versus 150 was the most, so that's what I'm saying, is that the clinical studies are missing out there. We have clinical studies, but they're really small cohort of population, which is a lot of work for physicians, but it's really important that we do more clinical studies. So this is, again, neuropathic pain only with cannabinoids, different type of studies and what type of cannabinoid they use. So Setvix, I will bring it up here, it's a combination of a ratio 1:1 THC CBD, also used as a spray, and it's been used in clinical studies to see if its efficacy. It's been debating if it's working in or not, depending on the pain condition. It's really specific to different pain condition. So basically, different cannabinoids, and as you can see here, the studies, the most is like 109 versus 230 for male and female. So studies are really small in numbers of patients, which we need to address that in the near future to have a better understanding. So this is the latest review. So we talked about sex differences in the endocannabinoid system and pain. And again, Dr. Henry Blanton too is the first author on this review. He did an amazing job. We did it in collaboration with Jenny Wilkerson, which will be coming actually in Amarillo as working as a research assistant professor, because she's part of the new SVPR group. So we will be lucky to have Jenny Wilkerson, that is also a cannabinoid scientist in the field of pain, and medical student Robert Barnes, Melissa McCain, my PhD student, Joshua, which was a pharmacy student back in Florida. So I wanted to acknowledge everybody from this paper and their help. And basically here, as you can see, we have really interesting, really looks like it's crowded. You can go look at the manuscript if you want some more details. This is an amazing figure by actually drawn by Henry. He's Dr. Blanton. I keep telling him and calling him Henry, but he basically is an amazing artist, also in a skateboarder. So for those of you who don't know, but anyway, he did an amazing job. And when we this is the study so far for cannabinoids, preclinical studies. I will show you some clinical studies, but this is preclinical studies in animals. And as you can see, there's differences here. Let's say for the amygdala, CB1 seems to have CB1 affinity is stronger for female than male. And all of these examples, there's big differences in the hypothalamus as well for male and female. Importantly, this is all of the brain, this is just for the brain region, hippocampus also. So there's differences, right? But we're just starting. This is for animals, right? So we need to do that also for humans and try to understand better how pain is modulated and how cannabinoids could be alleviating pain and the sex differences into that. So this is for the liver as well. And so the male and the female. So you have a mouse here. This is the preclinical studies. But as you can see here, the liver differences in the liver enzymes. So in for the female and the male. So just THC degradation for male and female mice will be different. So the testis and the ovaries differences here also, and for the nociception as well. So there's a lot of differences, okay? And the hormones are playing a role. So that's what I'm about to show you. Again, this is just tables for preclinical studies that we did, that other groups did, and that we put in that table with the authors of the studies, and then the type of pain we use, if it's acute pain, chronic pain, and basically the different compounds that they use, CBD, THC, as you can see, THC. So you guys can go look, but it's just to emphasize there's a lot of preclinical studies that have been out there. There's also clinical studies, as you saw in my previous slides, but we really need more studies, basically. Again, this is just to show similar findings about the different cannabinoids, CP and THC mainly, and basically GWH also, that I will show you some data. So basically from this review that I just showed you some of the tables and the nice drawing, basically major findings is that female generally report as more sensitive to cannabinoids versus male. And you'll see it in my study in a few minutes. The ovariectomy and hormones replacement will influence cannabinoid mediated anti-synaption. So that brings another component. And the limitation is basically a lot of studies have been done on THC, and there's sex differences in the metabolism of THC. So we need to look into that. We need to, a lot of focus have been on acute pain, but chronic pain is a problem in the clinics, chronic pain from chemotherapy-induced agent, from past injuries and things like that. So we need to focus more on chronic pain, and also sex differences, really looking into the effect of CB1 and CB2 and how does it work, basically. So this is, I'm going to show you now preclinical studies that I did in my lab. So this is just to show you, for those of you who never heard of the formalin test. So it's injection in the paw of basically 10 microliter of formalin, 2.5%. And what does the formalin test is, you will basically score these different behaviors, basically the no behavior, meaning no response. You will, if they are favoring the paw, meaning lifting the paw, or if they shake the paw or bite the paw, lick the paw. That's basically what we're measuring. That's what we're measuring every 5 minutes with a computer program. And when you measure that, what you see, you will have an acute phase 1, and inflammatory phase 2, and you will have a peak. So the first peak is acute phase in the first 15 minutes, and the second phase here is the inflammatory phase, and basically is the second phase that you will see. And if you have an analgesic compound, you will have a lower curve, which I'm going to show you in a few seconds. So this is this is to show you how we can evaluate the estrous cycle in female. So you can basically evaluate the different stages from proestrus, estrus, metastrus, and diestrus. So they cycle faster than humans, but it's around 4 to 5 days. But then you can basically measure, if you do it daily, the different stages: proestrus, estrus, metastrus, and diestrus. And there's different cell types. So for proestrus, you have nucleated epithelial cells. For the estrus phase, it's basically the squam epithelial cells. For the metastress, it's a mix of leukocytes. It's the dark dust that you can see, the dark dust here, cornified. And so basically all the 3 types of cells and predominance of leukocytes in the Estrous phase. So that's what basically we did in our studies. And basically this is to show you here sex differences in the formalin test. I just show you the normal formalin test, right? So you will be really intrigued by this data that I'm about to send for publication this weekend when I have some time to finalize that paper. But basically you have the 2 phases, phase 1 and phase 2, and you can see a small differences, right? Like for the male versus the female. Pink I use for female, blue, green used for male. As you can see here, there's a small differences, but I'm like, it seems small, right? So this is all of the female that I put. I put a lot of female for all of the different stages to generate this data. But then I'm like, what if I put all of the cycles separately? And that's what I'm going to show you here. So here what I'm showing you is basically for each of the cycle that I show you. So if the female was in pro-estrus, we did the formalin test that day, right? So pro-estrus and estrus, there's no differences between the male and the female. As you can see here, right? The curves overlap for the acute phase and the inflammatory phase. But then if you go to the metastress and the diestress phase, as you can see here, you have a lower pain. Female have lower pain than male for the metastress and the diestress phase for the second phase of the formalin test, which you can see also in the bar graph. This is just another representation of this phase here where we measure the area under the curve. So interestingly here, it's really dependent to the cycle, which means that if I put all of these, if I put all of the female at different stages together, then I'll miss differences basically, right? Which is really interesting. So in this, what we did is we did the male here, and we have the female sham, meaning they didn't have a surgery. We didn't took the ovaries. We just sham means you open the abdomen, you look at the ovaries, but you keep everything and you suture back. So it's the same control condition as the female ovarectomized. So, but as you can see here, if you take the ovaries, you have way lower pain in the inflammatory phase for the female compared to the male, and the female that don't have the ovaries have less pain than the female that have their ovaries intact. And then we wanted to evaluate what happened if I give estradiol. And if I give estradiol and the female that got their ovaries out, what I see here is I reverse the analgesic effect. Basically, the female that had their ovaries out had less pain, then I reinstate the pain right here. So it's really, really interesting, right? So this is what we did in that study, and now we're doing right now ovariectomy in chronic pain model and see what it does. So that's part of that. So now on this figure, I'm going to show you the effect of CBD in mice. And these studies are done in male. We'll have to do the female, so to be pursued or to be continued. But basically you have here the male have in the inflammatory phase have analgesic effect from CBD 2.5 mg per kg. So it does alleviate inflammation like I show you. And that's what patients are using it as anti-inflammatory, also an analgesic effect of CBD. You can see it also in the mice, and you can see it in humans because people are taking CBD now. For this part, it's also the formalin test. This is a little crowded, but this is ACA. This is a CB1 agonist, right? So only CB1. So CB1 psychotropic effect. So as you can see here, I'm trying to understand, and then you'll see when I'm finished with my talk, what is the involvement of the CB1 versus CB2 or the mixed agonist with sex differences, right? And there's no way we know unless we basically evaluate a CB1 or a CB2 agonist and a mixed agonist. So this is ACA, which is a CB1 agonist, and 0.5, 0.25, and 1 is different dose. It's mg per kg, and this is a little crowded, so we'll look at the phase 1 that I show you here, which is the same graph, but the isobar is a little easier to follow. So as you can see here, female mice have respond better to 0.5 and 1 mg per kg if you do a formalin test, versus the male respond to 0.5, and then 0.5 is a better dose, but 1 seems to be creating a little bit more pain than 0.5. So the ideal dose for the male will be 0.5, but for the female, they will need a higher dose, which is really interesting, right? And we're looking at the mechanism. So we have some tissue that we will analyze later to look at the mechanism. But you see how if you don't address the male and female, if in the past, that's what I'm trying to emphasize with my talk here, but in the past, sometimes if you have genetically modified mice, you will use both male and female together. We will group them because it's really time consuming to breed animals, and they will just pull male and females together in most studies. But then you will miss results or have conclusion that not necessarily accurate, right? In terms of the differences in the dose. So now I'm going to switch gear and go to chemotherapy-induced pain. And I have a lot of data, but I'm going to try to just give you like a clear picture here. And if you're interested, you can always email me. So this is the part of the review that I show you in drugs. So basically, there's different line of treatment for chemotherapy-induced pain. When chronic pain persists after the cancer is gone and people are in remission, and then they got a chemotherapeutic agent, and sometimes mixed with irradiation, it creates chemotherapy-induced pain that basically doesn't go away and persists chronically. And the cannabinoid is a new front runner with all of the legalization in different states to be basically alleviate chemotherapy-induced pain. So that's what I'm going to talk to you about. So here is the model that I'm using. I'm showing you preclinical data, but this is a mouse model that I optimized. It's Guindon et al. 2014. I optimized this model. So it's basically 5 mg per kg once a week. And what you do you give cisplatin, which is a platinum-derived compound, and you are able to look at mechanical allodynia. So it's basically digital electrovorn fry that you apply under the paw of the animals, right? And basically what you measure is the force in gram for the animals to lift its paw. So that's basically what you measure. That's what you're going to see in my slides I'm explaining before. And that's digital electrovorn fry. We have to thank Max von Frey that I showed you at the beginning of my first slide, that was one of the pioneer in having a cutaneous pain theory, okay? And cold allodynia is basically a nail polish remover or acetone that you put, and then it create a cold sensation, and you measure the time in seconds that the animal remove its paw. Without pain, it will take 2-3 seconds. If you have pain, then the animal will lick their paw for 7 to 8 seconds. So this is what I'm going to show you right here. So this is THC. So I am also guilty that this was done in 2013 and 14, but got published in 2020. And that was part of my R01 preliminary data. And this is THC. And at the time, the emphasis on female was not like as important. And then that was a study that I did just before I came here and be recruited. So basically this is THC and in male, and we're doing the studies in female. But basically you see this is when you establish. Here is baseline, no pain, no neuropathic pain with the digital electrovorn around 7 grams. Then when you have chemotherapy on board, you give at day 1, day 7, on day 8, you are around 2. And then if you give THC, here as you can see, you reverse pain, right? But you develop tolerance. So as you can see, it takes 1, 2, 3, 4 days and you develop tolerance. This is THC studies, right? So part of my grant is investigating THC and how you reverse it with JNK inhibition. But I'm not going to go into that. But we are finding sex differences in that aspect as well. But I can give another talk and talk to you about that in another time. But this is basically my model. So this is the same. It looks crowded, but this is basically mechanical and cold allodynia, what I talked to you about. So this is a digital electrovorn fry. You start here. You don't administer any chemo. And then when you start giving chemo on day 1 and on day 7, you see the curve goes down, right? So this is the animal that received chemo. And here we also evaluate for a cold allodynia, the cold sensation. So if they don't have pain, they take 2 seconds, they lick their paw, and then it goes high. So that's basically what we have here. So this is just to show you the model. And this is the animals that didn't receive anything. So they're stable. throughout. They don't have chemo treatment and they're stable right here for mechanical and cold. What is interesting is here. So this is the Estrus cycle. So these animals, we basically did look at the animal, the Estrus cycle daily on the slide. You put basically you do vaginal lavage, you put it on a slide and you stain it for crystal violet. And basically you can look under the microscope at the histology. It's a lot of work for the students and for myself to look at all of that slides, but it's really interesting because you will see the next slides. So if there's no chemo, and even with chemo or model, basically, if you graph all of these pro-estrus, estrus, and metastrus, the estrus with all of the color thing, you see the bar graph here, there's no changes. So if you were with saline condition, no chemo or chemo treatment, there's no changes. But be prepared for the next slides. So this is ACA, my CB1 agonist. And as you can see here, like THC, animals are no pain. We give chemotherapeutic treatments. Once the chemo is on board, male and female. So the pink is female, blue is the male. So ACA, CB1 agonist, we see that female develop tolerance faster than the male for the same dose. This is 0.5 mg per kg, right? Several days, right? So meaning in the clinic, it could happen too, that female will develop tolerance faster, right? So basically few days before. Same thing here for the cold allodynia, which is another pain modality. We just want to confirm female develop tolerance faster than the male. And most importantly, here, if you notice, there's a lot of yellow, right? There's a lot of yellow, if you can see here for the animals that receive ACA, which is the metastrus phase, meaning that, and this corroborate if you match the graph here to when they develop tolerance. So it seemed that when they develop tolerance, their estrous cycle is changing. So this is part of some new exciting data that I'm working on for my renewal. But this is really interesting that there's a change in the estrous cycle, and basically you can graph it right here. And that's what we have here for a CB1 agonist. So here is the same as all of the little colors. It's just I graphed it here, and you can see predominance of the mid-estrous phase, and then a decrease in the estrous phase when you receive chronically a cannabinoid. So basically, to be noted, the cannabinoid keeps being injected, but the animals have pain, basically, right? So we still give the cannabinoids ACA, but then when they develop tolerance, they still feel pain, but we still administer the cannabinoid, basically, to evaluate tolerance. So this is for AM 1241. I talked to you about a CB2. This is a CB2 agonist, and CB2 agonists are known to not develop tolerance. So as you can see here, for the male and the female, the gray is the male, the light pink is the female. If you give a CB2 for mechanical and cold, they don't develop tolerance. That's been shown. But I was curious about what is the effect on the estrous cycle, right? And here, when you give a CB2 agonist, interestingly, they are more in the estrous phase of the estrous cycle. So this is what I graphed here. So you have a lot of pink, and I graphed it here, and you have increase in estrous cycle. So this is all new data that I'm investigating the mechanism behind the change in estrous cycle in chronic administration of cannabinoid, which is really exciting. And we did ovariectomy in mice, and we're running the studies right now to see what is the hormones play in there. So these were intact females. So this is really exciting. So now what about the mixed agonist? If I have a CB1, CB2 agonist, which is CP55940, what will be the effect? So similar findings here. In purple, the female have received the CP55940. So for a few days, you alleviate pain, and then basically you develop tolerance faster again in female than in male. Same thing if you measure cold allodynia with the acetone. Here, female will develop tolerance faster than the male, and then you will also have a predominance of the metastrus phase, which we found, if you remember, with the CB1 agonist. So that you can graph right here. So basically, that's kind of what we're investigating is what is the mechanism, the different mechanism behind that, and if there's differences in pain markers or things like that, that we're going to look into that. So this is just to show you when we took the animals. So we took these animals and we basically, for the different compounds that I show you, we basically look at the estradiol levels. And what we could see, as you can see here, also we followed the cycle, and we also found a big increase in estradiol levels when we did the ELISA test for these females that received chronically M1241, and a decrease when they received the CB1 or a mixed CB1, CB2 agonist. For the males, there was no changes in testosterone levels when you give all of these compounds. So the male seems to not be affected as much hormonally for the same dose as the female. That was interesting for when we measure testosterone levels. And this is just to show you, I'm going to finish up with these slides. So this is the ovaries and the testes for these compounds. So we focus on this study on the CB1 and the mixed agonist. And there was no change in the CB1 or the CB2 expression for the ovaries for the female. But for the male, the testes, there was an increase in CB1 levels and a decrease in CB2 levels. So this is interesting. So that's basically, I'm investigating what are the mechanisms behind that. So we should complexify the studies, but it's really interesting. And this is interleukin 6, so inflammatory markers that are used. And basically here in the female, in the ovaries, you can see increase in IL-6 for if you give a CB1 and a CB2 agonist. Only the mixed agonist here, CP, will increase IL-1 beta for the ovaries. For the testis, you have a decrease in IL-6 if you give a CB1 agonist. So we need to kind of understand better, but what it tells you is that it's really different. And then we did brain and spinal cord, so I didn't show it to you in there, but there's different changes as well. So meaning that throughout your body, from the periphery to the brain, there's different changes that are hormonally driven, basically. This is just my latest baby studies. It's my new project with ovarian cancer. So this is, well, I wanted to evaluate in ovarian cancer. These are SID mice, so basically nude mice. And I'm doing currently my studies in breast cancer with syngeneic mice, basically with wild type mice and syngeneic cell line. But basically what we have here is we give ovarian cancer ectopically, and then we let it grow for 30 days. So that's what you can see here. And then I give a GWH, which is a CB2 agonist at 1 mg/kg, or a CB1 agonist. And I wanted to evaluate if there's differences in the tumor growth for cancer if you give a CB1 versus CB2, because my thinking is that patients that are, having cancer, sometimes because of the medical states where they legalize medical cannabis, they're taking, if they're taking THC, it's a mixed CB1, CB2 agonist. And I wanted to know if there's an effect of taking, if we can increase tumor growth, right? So if you want to take it to stimulate appetite, to alleviate pain, and things like that, but then does it have a detrimental effect on tumor growth? So that was my thinking. So anyway, what we found here is that CB1, this is if you have a tumor, because there's been studies out there when the tumor is at the beginning. But if you have a tumor that is full grown at 30 days, then CB2 increased tumor growth. So it's something to consider in the recommendation of medical cannabis for cancer patients, right? That needs to be investigated further, obviously, with other cells and things like that. But this is so interesting data. So I'm going to summarize briefly. Sex differences has been demonstrated in preclinical and clinical studies. Cannabinoid compounds have shown sex differences, male and female at preclinical level and clinical level. Females in my studies develop tolerance faster with CB1 versus mixed CB1, CB2 agonists, and we have increase in tumor growth with CB2. And I would not emphasize more that we need more studies evaluating the sex differences in preclinical and clinical studies to better understand and improve treatment of pain, cancer pain. And I would like to acknowledge everybody that worked with me on these different projects. So Dr. Isabel Castro, Dr. José Luis for growing all of these cells, Henry Blanton, first PhD student that just graduated, Melissa McCain, that is my second PhD student, Agatha Pierzak, that was a night of students that got a grant to study some of the cannabinoids, chronic pain studies, Jennifer, Ali Desel, that is an undergrad from TTU that has been wonderful this summer, Canis Denzel, that is a MD a second-year medical student that is doing amazing job and helping with the ovariectomy in female and surgery and things like that. Dan Morgan, my collaborator, and MPI on that R1 funding and startup funds. And thank you so much for your time.